Good night, Dorian. Can you hear me?
Good night. Yes, we can.
Okay, great. How are you? How was your weekend?
Pretty neat. That's good, I think.
Okay, great. Well,
Uh,
let me see. Well, only two people. Let's wait for your classmates, okay?
okay.
Start. I think we can wait for 5 minutes, could be, and then we start.
Okay.
Is that okay for you? Okay,
No
great.
problem.
Okay, I'll be back in 5 minutes, okay?
Okay.
Okay. Okay, good night, everybody. Can you hear me?
Yes, miss.
Yes, teacher.
Okay, great. It's 8 and 9, almost 8 and 10. Let's start. Chat. Great. So tonight we are studying the model 2 in this course, basic course in medical English. And we have to consider lots of important details, okay? Just as an introduction, let's make a fast review of Model 1. When we had the chance to check anatomical reviews, charts with pathologies, some specific situations, we started writing down the key report and, well, basic information, I can say, when we had the chance to work a lot memorizing, okay? Memorizing information, anatomical details, well, a very general view. In Model 2, we have the chance, as I was telling you in the first presentation the day when we started the Model 1. Model 2 is for writing down more, for practicing more how to give information to our patients and how to read investigation, okay? That's why this class is not too long. Well, almost all classes in Module 2 are not long. They are exactly 1 hour. This class is shorter than the rest of the classes, but it's important. We are going to talk about basic investigations. Basic investigation focused on medical investigation specifically. Certainly, what do you think? What do you understand when I give you this idea about basic investigations? What idea is getting to your mind? Maybe, let me see. I'm gonna call someone and he's gonna give me the possible answer. What do you understand with this term, Pablo? Can you hear me, Pablo? Is that possible for you to talk now? If it's not possible, send me a message to the chat. I understand that you are working and studying at this time, maybe finishing or maybe going home, and well, it's a risk to go with the cell phone on the street, right? Okay, Pablo, I understand. Okay, what about Alejandra? Alejandra, what do you understand? Alejandra, can you hear me?
Yes, miss.
Okay,
The basic investigation for me is the search information about the medicine.
okay, about medicine, about the topic we are looking for, right? It's a good way to catch, to understand this previous meaning. It's an important meaning, I say, because when we talk about the basics, we must consider that they are resources that don't require too much devices, don't take too much time, okay? When we say medical investigation specifically, of course, this investigation focused into medical terms, into our topic, to our patient, could be said in a good way, okay? So let's see at the beginning. Investigation is a systematic and thorough examination or inquire into something or someone. The collection of facts of information and the recording of this examination or inquiry in a report. We collect information, we prepare our report with a conclusion, and that's investigation. That's the way to collect properly the investigation, right? Right. Same happens with our patients. We start making investigations no matter if it's basics or not, just investigations. And we collect the information, we collect the results. We have a reason why we ask for that kind of information or facts. And then we prepare our medical report. So medical investigation is all the complementary studies that we request in order to support the diagnosis. I mean, all the complementary studies could be by clinical, extra medical exam, maybe extra maneuvers, extra procedures that we decide to develop, lab tests, x-rays, well, anything that is going to complete to support our diagnosis, it's going to be medical investigation. Lab tests, imaging, more imaging, different projections. Of course, we have a doubt, we have an idea what is going on with our patient, which diagnosis could be. And then we ask for this kind of studies. It's not by free, we all know that. We know that we certainly need to get, we have to know what we are looking for. That's why it's important for us to keep on reading, to keep on studying, keep on practicing. Well, this joke is so clear, it's focused on this. This test is to see if we need to do more tests. Of course, we start asking for the basics. The basics are these ones. The procedures that we make are the basics, and according to that, we decide what to look for. Which studies we must ask for in labs, in the imaging, I don't know, in anything, right? When we talk about procedures, we must understand they are part of medical investigation. They are part of the basis of our clinical ideas, of our clinical thought. And according to that, we have the chance to start looking for details. For example, if a patient goes to your consultation complaining of headache, what do you do? Different from the anamnesis, from all the questions you need to ask for. You take the blood pressure. You make this basic investigation, this easy one, non-invasive, in order to support that blood pressure is into the parameters, and there is no way to start in front of a high blood pressure debut, maybe, or maybe something different. Of course, we look the heart rate, the pulse, right? When we look for this, when we evaluate just this parameter, we look for specific pathological situations, for example, tachycardia, an arrhythmia, or something like that, that could give us a value that is supporting that we have to look for extra details. The same with respiratory rate or temperature or blood oxygen. And ophthalmoscopy. In Latin America, in general, we don't have the custom to develop this procedure, because certainly we don't have enough practice at the moment to finish medical school. But if you go to USA, to UK, France, Italy, well, to Europe in general and USA, you might notice that this procedure is a fact. You have to develop it into the emergency room and in some consulting rooms and in the hospital or in the clinic for outpatients, right? Of course, we need practice, but we have to look for this. Why? Because there are some findings that can focus and can show us how some complications of pathologies that are not being detected at the moment when the patient is going to the consultation, to the consulting room, right, to the appointment. All of these procedures, as I was telling you, are the basic ones, the easiest ones, in order to start organizing the medical thought. That's why we know we have to look for this at the beginning of all consultation, of all interview, of all appointment with our patients. Just as an extra information for catching vocabulary, we have the normal parameters. They are from the sea level. It could be different in your countries, of course, are different from mine, but you have the chance to compare this, to practice with this, just for making a review. Some of these values are not the actual ones following the American Heart Association for blood pressure, for example, but it's possible to study with this, to catch the vocabulary and of course catch abbreviations. Similar to Spanish, of course, but not the same. Alexander Tatarin is a nurse in USA. I'm not sure in which state, so don't ask for that place, but he is the author of many books when he shows how to treat patients, like an overall snapshot, I mean, like a well-being, like a person, not like a number, not like just a pathology. He showed us that vital signs is providing us clinical information just as an overall snapshot. I mean, just in a specific moment when you are evaluating your patient. So, you take the vital signs, for example, at 7 a.m. You go back to evaluate the patient again, you go to the ward round and evaluate the patient again. 3 p.m. you take the vital signs, they are not going to be the same. Because that screenshot of the patient, that overall snapshot of the patient just was at 7 a.m. And through the time, the situation could change. That's why we have to be so clear in this. Vital signs always change. They can help to determine treatment and management plans for patients when taken into consideration with other data points. Of course, we need extra information, physical exam, the patient's speech, maybe the Glasgow Coma Scale must be evaluated again. Well, we don't know, it's according to the situation. We know what we have to look for on this point. When vital signs are abnormal, we must check always how the patient is doing. Sometimes these devices, electronic devices, fail, and we don't have to be scared about it. If clinically the patient is not showing the values that are here, take it by manual. We have all the devices. I mean, it's a rule that all hospitals all over the world has to have a stethoscope and a sphygmomanometer for working by hands, right? So it's possible to make it. And well, we have to continue, we have to look for the correct information, right? Remember the patient as a whole. Well, treat the patient as a whole and not just as individual numbers. Nowadays, it's a critical problem that we usually evaluate the patient and consider that this patient is just the pathology, not a person. We have to change the idea through the time. I think it's possible at this point. In model 1, we're checking the stethoscope in one slide presentation. And we only got the definition, how it works. But now we are going to check a little bit through history. Medical history is amazing. And we must remember who's this doctor. He's Ronald Nack. Does anybody know something about him? Maybe someone who read something about this doctor, because he's the doctor who developed the stethoscope actually as a tube at the beginning. And now, I'm sorry. And now the actual ones we have. When he developed this device, of course, as a doctor, he had to hear lungs. And for not placing the ear on the chest of a lady without clothes, as this kid is, he decided to prepare this device, just a wooden tube. This tube amplifies the sound, and through the time, this device was changing. You can see lots of shapes. This is the Pinart stethoscope for here in the tummy. And then that's the way he was working at the beginning, placing the ear on the patient chest. When everything was changing, well, when he catch how to develop his device, he called it a stethoscope. Okay. At the beginning it was mononaural, but through the time it's changing, and nowadays it could be electrical too, and records sound, records the heartbeat. It's amazing how this device is changing through the time. And of course, using this device, we avoided some contagious infections. That's why it's important to remember this, okay? We know the stethoscope has lots of parts. Anatomy of the stethoscope, we can say. We get the air tips or air plugs that are synonyms, the air tubes, metal tubes that usually are adjustable binaurals. We all know about it. This part is the headset. It's placed on the head of the doctor. We all know about it. The binaural spring, and then we get the flexible tubing, rubber tube. We got about it, and we have the chest piece as a whole, the dual head chest piece, turnable diaphragm. We got the bell, the big one. Oh, I'm sorry, the small one with hole. The bell is this one, the small one with a hole usually. We got the drum, just the big one. We got the diaphragm, the white one, that piece is possible to exchange. And the steam is all of this head as a group, okay? Then we got the sphygmomanometer, again, the parts of it. We have the inflation valve, air release valve, the pressure cuff, the index marking, of course, the aneroid manometer gauge, artery position indicator level, and the tube connectors. Of course, we all know for culture, we must know about it. Let's start. When we talk about the basics, we must divide it into invasive and non-invasive. Invasive studies, the ones that cut the skin or punch the skin. Non-invasive, all the procedures that doesn't have to make an injury. It's an easy way to understand this difference. Specifically, vital signs, all of them are non-invasive procedures. That's why the first one is the blood pressure, abbreviation BP. This non-invasive procedure measures the pressure of circulating blood against the blood vessel wall. We all know about it from medical school. We are checking through maybe in high school too, but we catch this idea. This pressure against the blood vessel wall is the value we are hearing. The top number is the systolic BP, amount of pressure that your heart pumps through your arteries and entire body. And the bottom number is the diastolic BP, is the amount of pressure in the arteries and body when your heart is at rest. We all know about it. Just a review how to express this definition. How it works, we all know how it's. The rubber cuff is surrounding our arm, then we send some pressure. When opening the releasing valve, we leave the air, and then the manometer is catching the value, and we hear the pump with the stethoscope. That's all, how it works, okay, easy to make, just a review. We have electrical ones, of course, with its own parts again, the display, the air jacks, the marker again, the marker for not wasting time and placing it wrongly. And we have ones that go to the wrist. We have to be so careful with this because if it's wrong placed, it's not going to take the correct value. 2 fingers from the wrist articulation as a fact, and then it's possible 2 fingers, don't forget, 2 fingers of the patient, not yours, okay? And if batteries are low, the value is not going to be correct. We have to be clear on this. They might send you a wrong value and it's not possible to make it. More details about it. When we can check some tips for accurate measurement. how to evaluate if it's well done or not and what not to do. Just extra information for practicing. It's not going to be homework or something like that. Okay, don't worry about this slide. And what the boss says, I mean the boss as American Heart Association. Why as a boss? Because this association is the worldwide association that rules how these parameters are gonna be evaluated for us as doctors. This is the last classification, but if you had an actual one, that's correct, okay? As we know, there's just 2 stages, and then we have hypertensive crisis, okay, just for extra information. And the American Heart Association, as I was telling you in Model 1, is supported by the American government. That's why we take it in account as a rule, what information they bring in order to work properly, okay? Extra information, values for BP in different ages, the minimum, the normal, and the maximum value that could be expected. It's for you, it's extra, don't worry about it. And now we got it. The rate, the heart rate, the pulse, abbreviation IHR, or just P, okay? We know is the amount of times that heart beats per minute. Of course, this is the abbreviation for beats per minute. Oh, okay, don't worry about it. It's the wave of blood created each time in the left ventricle of heart contracts and how it moves through to our arteries. Each pulse beat is 1 cardiac cycle or 1 heartbeat. We all know about it. And values, the normal one is about 70 times per minute. It's a per medium. And the increased oxygen results in faster pulse rates, just extra information. We got tachycardia and bradycardia, just for you. Okay. The average pulse rate by age. Again, next information just for showing you details on how to express this idea. And common pulses for taking the blood pressure. These sites are so important. Radial, the most common. Brachial, for taking the BP. Carotid, when we evaluate emergencies. Temporal. This one, if we evaluate the emergencies too, according to the situation, we decide if we can take it in carotid or temporal. Femoral and popliteal, in trauma specifically, looking for the blood supply to the limb. Posterior tibial and dorsalis peris, again, looking for the supply, but it's with more time. You need practice to catch those ones, and the apical, okay? Steps for measuring the radial pulse is for you, for practicing. So let me see, let me ask someone. Diana, can you hear me? Diana. Or maybe Jimena.
Sorry, I'm here.
Hi, Diana.
I'm driving. Sorry, I was driving, so I wasn't able to touch my phone.
Okay,
but
keep driving. Don't worry about it.
But no,
no,
I think I can like park somewhere so I can read.
Is that okay now, or do you prefer to get later? There's no trouble on me.
Oh, well, I'm close to my home, so if I get the chance to participate later,
Okay. Okay, I'm gonna call you later. Don't worry about it.
Thank you.
Okay, let me see. Laura Yawita, are you there? Can you hear me?
Yes, teacher, I can hear you.
Okay, Laura, can you read this slide, please, from step 1 to step 5, okay?
Okay. Step
Okay,
1, perform hand EGM, identify the patient. Step 2, explain procedure to the patient and ask the patient about any present physical activity or smoking. Step 3, ask the patient to sit down and place arm in a comfortable supported position. Step 4, place fingertips on radial artery or down side of wrist. Step 5, to check the quality of pulse.
Okay, thank you. As you can see, just for taking pulse, we got 5 steps. We got a way to do it until this point. Now we got the 6 and to 9. Right? Yes. All of these steps are showing us in a specific order how to do this procedure without making a mistake, without working fully, we can say, without wasting time, because we don't have time for doing this. Step 6, start counting pulse beats when second hand on watch. I see 3, 6, 9, or 12. Of course, we know about it. Step 7, count the pulse for a full 1 minute, not 15 seconds, not 30 seconds, not 20. It's not correct to count 15 and then make the multiplication, make the value by cross by 4. It's not possible to make it. It's not correct, but we make it because it's practical, right? Step 8, immediately write the pulse beats per minute on a piece of paper for not forgetting the value. And then step 9, again, perform hand hygiene and record the pulse beats per minute if the patient's record. We all know about it, okay? Talking about the respiratory rate, important basic investigation, we must consider that we evaluate which breathing occurs, okay, at the moment. It's usually measured in breaths per minute, I mean BPM, the same as beats per minute and breaths per minute. The difference is the context, okay? Again, it's usually controlled by the respiratory center. We'll know about it. And during this evaluation, we take in account the pattern, effort, and volume of respiration. These values are showing us are an indicative of altered respiratory physiology. You remember in the in the third presentation, I sent you some slides with different respiration patterns. So consider this information, contrast these values for practicing and catching the vocabulary we must practice, okay? Several per-hospital and hospital-based illness or injury severity scores feature the respiratory rate as a cardinal value, of course, because if we don't receive properly the oxygen, it's not possible to make a good job, right? Again, it has steps to measure the respirations, to take the double R. For example, again, we perform hand hygiene, of course. We identify the patient, and we get the patient into a comfortable position. We have to place hand on the patient's wrist in position to take the pulse for switching ideas to the patient. And if the patient is thinking we're taking the pulse, we're taking the breathing. And we observe and count each breathing cycle. Again, 1 full minute must be used for counting this. And we record all this information in the patient charts, and we finish with the hand hygiene again. The core temperature, of course, basic one. When we evaluate the temperature of body's internal organs, I mean, the normal temperature range is between 36.5 and 37.4 Celsius degrees. It's for Latin America, of course. In USA, they have another value. In UK, they also use Celsius degrees. Okay, but temperature readings vary depending on where it is measured. I mean, it's not the same in head than axilla or maybe another place, right? The core body temperature refers to the temperature of the body's internal organs, such as heart, liver, brain, and blood, of course. This chart is showing us how it changes according to the place and according according the place you are as patient and according the body position you decide to take this parameter. In a cool ambient temperature, we got all of these differences. Or in a warm ambient temperature, you know it's different. The core, 37, 36, 32 in arms, in shell, okay, 28 by hands, 34 and 31 by legs. Just as an extra information for practicing, for catching the meaning, how it works, okay? In this chart, the yellow ones are the acral regions that help to control body temperature by constructing blood vessels when the body temperature falls. I mean, if it's a cool place, your hands get so colder, it's because these constructed blood vessels, okay? Just for that, we all know about it, just for making a review. Other places to take the temperature, of course, oral temperature, of course, behind the tongue, the tympanic temperature, in my opinion, the best when you treat kids. Rectal temperature, when you treat babies, it's the best because there's no way to fail on this. Then we got the skin temperature with this bandage that in my opinion is not practical, but it's very useful by parents. I don't know why they like it. We got the temporal or frontal temperature with this electronic thermometer, like a shot, as was so popular during the pandemic times. And of course, the armpit or the axillary temperature. Okay. Mercury thermometers are not nowadays so popular to watch because mercury is toxic, and get one thermometer broken could be a trouble because of the poison doses it has for working properly. That's why they are not common devices now, and it's easily to find electronic devices. But again, if batteries are low, the readings are not going to be correct. We have to be clear on this. Okay, blood oxygen. The blood oxygen level, of course, measures how much oxygen is circulating in your red blood cells at the moment. Okay, you cannot take the blood oxygen level in the morning and think that it's going to be the same at night. Of course not. As we were checking in previous slides, we know that all vital signs are going to change through the time, all the time, because they are dynamic. They get into range, but they are not exactly the same all the time, okay? You can measure your blood oxygen level with a pulse oximeter, this device, the small one, very popular during the pandemic times. All people try to get one in order to control the blood oxygen level if they were with COVID. And it was a good point to analyze and good point to take care at home. And if the value was changed according to the place, in Bolivia, in La Paz specifically, if it was under 85, it was an indication to get into the hospital, to get admitted, right? And if it was under 80, of course, it was for going into the intensive care unit for using the mechanical ventilation, of course. 85 is the cohort in La Paz because of the attitudes. It's not the same in Santa Cruz, it's not the same in Cochabamba, it changes. Of course, in different countries that are in the sea level certainly need to clarify that blood oxygen has to be up than 95. An indication to start using oxygen is 95, right? To think on being admitted in the sea level is 90. And to start thinking on the intensive care unit is 88, not 85, 88. Here in La Paz, we live in 3,600 meters upper the sea level. It's not the same to be in the altitude that being in the sea level. Of course, the physiology in respiration is completely different. This small device has a laser And this laser, it's not here. I thought I said the picture. Well, this laser, the red one, catches the arteries, the capillaries, and take the information from this small part of the blood. If the acral zones, the most, the blood that is far away from heart has a correct blood oxygen level, everything is correct, so don't worry about it. But if it's failing, if it's a lack, of course, everything is changing into our body. Easy to use, easy to practice on this. We all had the chance to check. We got some levels to consider this one. According to the attitude, this chart is for sea level just, so extra information, don't worry about it. Now let's talk about ophthalmoscopy. Ophthalmoscopy, again, a non-invasive procedure that has to be developed by a doctor, not by a technician, and not necessarily by an ophthalmologist. In emergency rooms, I was one of the doctors who tried to introduce this procedure for all the patients because it's important. Some patients don't know they are diabetic and they just notice this disease when they get some consequences and there is no way to get a solution, right? Or for hypertensive patients, for making a control and looking for chronic changes. An ophthalmoscope allows the doctor to examine all parts of the eye, the iris, the lens, retina, and optic disc. Right. For best results, the examination is done with dimmed or lowered lights. I mean, dimmed or lowered lights to allow the pupil to maximally dilate or widen, okay? Dilate. A topical mydriatric solution may be applied to the eye to aid dilation if it's necessary. The patient is then asked to fixate on a target for the duration of the test. I mean, the patient has to wait until the medication, the topic mydriatric solution pass away, finishes its job, I mean, and then it's possible to walk without troubles. When the pupil is delayed, maximally delayed, you receive all the light into the eye and it's not possible to see. That's why you have to develop this procedure if it's necessary, and then the patient has to rest, has to stay for taking care of him or for taking care, okay? Right. Again, parts of this device: the viewing window, the lens wheel, lens power scale, of course, this is the doctor place, the light adjustment color, and the power base and handle. Again, that's the place that the patient is going to watch. That's the mirror, the color adjustment button, the temperature adjustment wheel, of course, and light adjustment color, right, and the power base and handle. Just for showing you, for catching the idea how it is. Then we have the direct method and the indirect method. Of course, it really needs more practice, the indirect one, because you use an extra lens for practicing this, for developing this procedure. And now we have a picture when we can check what we are watching. We see the blood vessels, physiologic cup, the optic disc, of course, the macular area, and the fovea. And with the indirect, we got the same view, just with an extra lens. And now it works. That's a picture from a normal ophthalmoscopy. This is a maximum dilated pupil in a patient that is just by a control. And that's there are details that we are looking for. Optic disc, the macula, blood vessels, and then we have some pathological situations. We got hemorrhages and exudates. Checking more more charts, more pictures for extra information. Just we got vitreous, the intravitreal, preretinal, hemorrhagia. All of them are according to trauma. The preretinal also hyaloid, typically single or in small groups. You can see this. Or superficial intraretinal is for trauma. All of them are for trauma. Okay, the deep intraretinal, the retinoschisis, subretinal, again, subretinal pigment epithelial. Okay, just extra information for checking differences if you had the chance to evaluate a patient with this procedure. This is a diabetic retinopathy. This is imagine it's a common one when you have these silver lines. It's called like them. Size of hemorrhage next to it, because that's the chronic changes that diabetes causes to the eyes. And now we have some pathologies to evaluate. Optic disc edema. This is the optic disc edema. You can see it's not as clear as it has to be. If you compare this one to this one, that's different, right? Hypertensive retinopathy, grade 3 or 4. You can see how the blood vessels are changing and are getting different from the normal position. You can see it's not normal, but it's better than this one. Then we got intraocular hemorrhage. You can see lots of blood here. And the optic disc pallor. This pallorness, it's not a good point. Okay, we have to look for troubles in retina. Just extra information. So we got findings of the acute retinal necrosis, how it changes through the time. It's so fast. It's a procedure that goes in around 1 month, and of course it's a cause of blindness. And all goal without a plan is just a wish. Just a wish, okay? So let's keep on reading. Let's keep on practicing. I'm glad to see you now, because I know that you are here because you want to continue in this course. And I really appreciate this. I really appreciate this effort. So we are going to work in the same way. I'm gonna send you the slides while you are filling the pool, okay? Let me send you the pool, and then you can check, you can receive the slides into the Zoom chat. Okay, can you all watch the pool? Hello. Okay, great. All of you could watch the pool. Is someone who couldn't check this information, who couldn't fill the pool maybe? Hello. Jimena, could you fill the pool?
On the chat, I fill the pool.
Okay, great. Okay, thank you. Because there is one who's not filling the pool. It's attendant.
I can't.
Jimena, okay. Okay. Okay, we are going to use the same procedure in the previous module, in module 1. And it's taking time to upload the slides. Give me a minute, please. Jimena, with you, I'm gonna send to the academic supervisor your attendance with a picture. That's the only way we are working because it's not possible to correct this. Okay, the slides are in the Zoom chat. Please download it and let me know that I got it or yes or something to catch that you got the information, okay?
Okay.
Okay, thank you, Laura. Okay. Laura, thank you. Perfect, Diana, thank you. Great. Diana, perfect. Alejandra, Dorian, and Elena and Jimena, can you download the slides? Perfect, Dorian. Bye-bye. See you tomorrow.
Got them, teacher. Thank you.
Great, Alejandra. See you.
See you. Bye.
Bye-bye. Jimena and Jacqueline, could you download the slides? Jimena and Jacqueline. Hello. Could you download the slides?
Okay, teacher. I try to slow down, but I have problems with my cell phone. Could you send me box, please? Material, please.
Okay, I'm gonna try because I have troubles with my laptop and my cell phone. I cannot connect them. I'm gonna try.
Then,
If
please.
I, please give me some, give me time to do it, okay? To fix this trouble, okay? I'm gonna send it to your inbox.
Yeah, okay. Bye, teacher. Bye-bye.
Okay, bye-bye. What about you, Jimena? Did you get the slides?
I can't as well. I can't as well. Please, can
Oh,
you
you
send me-
cannot download it. Okay, I'm gonna download it, same as Jacqueline, and I'm gonna send it to you, okay?
Okay, thank you very much. Miss.
Okay, see you.
See you, Dr. Iris. Bye-bye. Have a
Bye-bye.
nice night.
See you tomorrow. Tomorrow we got this workshop.
Okay, Miss. Thank you very much.
Okay, bye-bye. Okay, everything is done.